Hi, my name is Dr. Lewis Au. I'm a medical oncologist at the Peter MacCallum Cancer Centre in Melbourne. And we've got here with me Professor Ananya Choudhury, who's one of our international faculties at ANZUP 2023. She's a professor in clinical oncology or radiation oncology with an interest in bladder cancer. But Ananya, I might get you to actually tell us a bit about your work and what your interests are.
Of course. So I'm a clinical academic based in Manchester at the University of Manchester and the Christie NHS Foundation Trust, which is the largest cancer centre in the UK. We're a comprehensive cancer centre, so we treat all cancers. And as a clinical oncologist, I actually treat both radiation oncology and medical oncology, which is a bit unusual, I think, over here in this part of the world. As a result, the research programme that I run is primarily focused in bladder and prostate cancer, but actually covers a lot of different aspects within that. We broadly focus on personalised radiotherapy, which means that we're looking for ways of trying to improve the treatments that we give to our patients, both by making our treatments better and smarter and more accurate, but also seeing if we can find ways of selecting the right treatments for the right patient. Part of the programme is based in, advanced radiotherapy, using advanced radiotherapy techniques such as MR-guided radiotherapy, hypofractionation, and also mathematical modelling to try and use big data to select patients for treatments. And then the other half of the programme is focused on biomarkers and using biomarkers to stratify patients, whether that's imaging or tissue biomarkers, but also, using biomarkers as well to understand the biology of cancer, to see if we can discover new targets and possibly new treatments in the future.
Right, yeah. So, that's definitely the next frontier in the treatment of cancer patients, is to be able to personalise treatments to individual patients. And that was the talk that you've just given, actually. You opened the talk by saying bladder cancer is an excellent model for understanding and developing personalised medicine. I was quite taken aback by that in a really exciting way. Would you mind elaborating on that?
Yeah, absolutely. So I'm a firm believer in the fact that we can learn a lot from one cancer and then apply it to other cancers. I think bladder cancer is particularly interesting because, first of all, it's in men and women. So it's not a sex-specific cancer like prostate cancer is, for example. So we can learn things about the effects of sex on the cancer. It's a cancer that can be treated with surgery, radiotherapy, systemic treatments. It responds well to a lot of the novel agents like checkpoint inhibitors and immunotherapy, and therefore it's a very diverse cancer. It's very heterogeneous, and therefore it's the sort of cancer for which I think there is not only a real need for personalised treatment in medicine, but also it provides a really good model for investigating the different aspects of biology that we can use to try and make those selections.
Yeah, and you're right. The treatment of bladder cancer almost uniquely involves pretty much at the same treatment time points, different modalities. As you've said, surgery, radiation, or systemic treatment all come into play at simultaneous time points, and that in itself poses as a challenge in generating evidence and biomarkers and personalised care. How do you think about that, and how do you think the field needs to approach it, understanding this is a major challenge?
So I think it is a major challenge. I think over the last couple of decades, we have identified a lot of really important questions. I think some of those questions we are some way to answering. So, for example, there's a lot of work going on in trying to classify bladder cancer according to its biology. Molecular subtypes, for example, have come to the fore. And as a community, we're now trying to make sure that we know what we're talking about when we're talking about molecular subtypes, that we're trying to standardise those concepts globally. And having got to that place, and given the fact we can classify bladder tumours, I think the next stage is to try and work out what that means for clinical application. And that's a bit that I don't think we have done yet, and we need to focus in that area. So I don't think we know, for example, which biological biomarkers we need to use to select patients for treatment. You know, which patients are going to be better served by systemic treatment followed by surgery in the radical setting, or systemic treatment followed by chemoradiotherapy in the radical setting, or even those patients who maybe we need to have a discussion about the fact that we don't have treatments that are going to cure them at the moment, and actually what we need to do is try and control their cancer and manage their cancer for as long as possible.
Yeah, yeah. And if we focus specifically on radiation therapy, there's been quite a lot of advances in different techniques as well in the last decade or so. What about generating evidence in this evolving treatment landscape? Looking at predictive biomarkers, what technique should be used for which patient? You mentioned one particular trial, it was the RADAR study that looked to try and answer some of those questions.
So I think this is really interesting, and I think here radiation oncology has a lot in common with surgery. Is that we have a specialty that deal in technological advances. You know, for example, the surgeons got their robot. In radiotherapy, we got intensity modulated radiotherapy. We got image guidance. We're now looking at MR related image guidance, and it's how do we use those technologies smartly and appropriately. And actually for me, what's really important is using them in a cost-effective way, because these technologies aren't cheap. An MR-Linac, which is a linear accelerator with an MR imaging machine integrated into it, costs about 4 times a high-end standard linear accelerator. So that's a huge investment just with the hardware. There's then upskilling your radiographers, your physics team, your clinicians. A lot of these technologies take longer to treat patients, so you don't have the throughput that you have with other standard technologies, and all of that sort of has to be looked at when you're designing your clinical trials, so that not only are you looking for a clinical advantage, you're actually looking for cost effectiveness as well. And I think both surgery and radiation oncology have found that challenging. And it's only now that we're starting to get some data whereby, for example, in the UK, not in bladder cancer, but we have a number of clinical trials where we're comparing proton radiotherapy with photon radiotherapy. And we could be in a situation where we show that there's no difference, and proton therapy is really expensive. So I think it is really important we do those studies. I don't know that we have a robust framework to do that, but I think at least we're thinking about it.
Yeah, and it's an important conversation to have as well. And as a medical oncologist, I think in terms of predictive biomarkers, it's often about tissue-based biomarkers or blood-based biomarkers, but you raise a real interesting concept about functional imaging being a dynamic biomarker that can be added on for radiation treatment. Do you want to elaborate a bit about that?
Yeah, so we have a really exciting program in Manchester where we have decided to focus on MR imaging, and functional MR especially, as a biomarker for both at baseline for selecting patients for treatment, but actually more interestingly maybe is monitoring the changes in the tumour using these imaging biomarkers during treatment. Because one of the difficulties I think with tissue biomarkers, especially in something like bladder cancer, is how do you get longitudinal samples? For me, as somebody who gives radiotherapy, asking my patient to have an invasive procedure during their treatment, just so I can get some tissue, if you like, to do some really interesting science, feels like a very big ask. And if I were to do that, I would put my patient at risk of infection or trauma because of an invasive procedure, and therefore I think you'd have to think about it very carefully. Whereas doing a scan on someone in the, into their treatment a week, 2 weeks, or even every day is a much smaller ask and actually is unlikely to cause much problems for the patient. And most patients are likely to say yes to that. So I think the big advantage that imaging biomarkers have over tissue biomarkers is that the accessibility of them. I think the challenge with imaging biomarkers is that you really do need a team that have a lot of expertise and a lot of experience, because what we've seen with other imaging studies is that often, even in the same department, no two imaging machines are the same. So you can get differences in doing, even when you do the same sequence on the same patient, between two different scanners. And if you multiply that across a multi-center network, then you immediately start to see there's quite a challenge in developing a robust, reproducible imaging sequence that can be used as a biomarker internationally.
Yeah. So where are we now, actually, in terms of predictive biomarkers of radiation response? Are there leading candidates for predicting radiation therapy response in bladder cancer? What's the current landscape of research?
So there's a lot of research going on in trying to have predictive biomarkers for treatment. A lot of that research to date has been based on immunohistochemistry, but immunohistochemistry, although it's cheap and accessible, can often be very difficult to reproduce and score accurately. And so people have moved into transcriptomic signatures. So there are a number of different transcriptomic signatures in various levels of development. The one that has been commercialized is the Decipher signature that looks at molecular subtyping. That has been validated retrospectively in a number of different cohorts, but it is yet to be prospectively validated or qualified. And there is a move to try and do that in a UK study, actually not for radiotherapy, but for neoadjuvant chemo. And I guess that hopefully then might lead to other studies for radiotherapy. From the work that has been done from various biobanks from clinical trials, probably the biomarker that's been most robustly validated is the hypoxia signature that's actually come out of our lab. Because that's been validated prognostically in a lot of retrospective cohorts, but it's actually been validated within the Beacon study, which was a UK radiotherapy study that compared radiotherapy alone with radiotherapy plus hypoxia-targeted treatment with carbogen and nicotinamide. So within that study, we had patients who'd been treated with hypoxic modification and patients who hadn't. And what our biomarker does is it not only selects the patients with hypoxic tumours that do better with a hypoxia-targeted treatment, but it has a significant test for interaction, which means that it has a high predictive power. And what we need to do is to take that biomarker and test it prospectively. So we have designed a study whereby patients with bladder cancer will have their hypoxia signature determined up front. And then those patients will be randomized to either chemoradiotherapy or chemoradiotherapy with hypoxia targeted treatment, regardless of what their biomarker status is. And that's really, really important, because that's the only way that you can truly qualify the biomarker, is to see basically if in an unbiased population you get a bigger effect in the biomarker positive patients than in the biomarker negative patients. A lot of studies try and pre-select the patients with the biomarker before they randomize them. And the problem with that design is that you're assuming that the biomarker is predictive. You're not trying to determine whether it's predictive. So if we can get that study funded, then I'd be delighted to come back and tell you whether our biomarker works or not. But obviously, if it did work, that would be a huge gain, I think, for patients. Because for the first time, we'd be able to say, this is the status of your tumour. If you have hypoxia-targeted treatment, we will have a much higher chance of curing you than if you don't.
And I guess the last question then, where do you think we'll end up in say 5-10 years time in terms of predicting responses to radiation therapy for bladder cancer? What would it look like? Would it be a combination of what you're suggesting and measuring tissue biomarkers and metrics in combination with radiographic biomarkers? Where do you think we'll end up in the future?
So I think cancers are pretty clever and very complex. And I suspect that there will never be a single biomarker that will be able to select patients in a black and white way. We will always be dealing with probabilities. And I think we can improve those probabilities if we use multiple biomarkers. And that's where I think my colleagues who are clever modelers and mathematicians and computer scientists can really help us. So one of the aspects of our program in Manchester that we're keen on is actually real multidisciplinary working, which I think fits fantastically with ANZUP's ethos as well. So within our group, we have clinicians, physicists, mathematical modelers, biologists, computer programmers, imaging scientists, all sorts of professionals coming together. And I think in the future what we will do is we will garner as much information as we can from the patient. So there'll be patient-related factors, there'll be the known prognostic factors. We'll look at the biology, both from the tissue, but also from the imaging that we do. And we will use all that information to model and create an algorithm to select patients for treatment. But then during treatment, we will be able to take data from imaging, potentially from liquid biomarkers like cell-free DNA or proteomic profiles or metabolomics or all sorts of other cutting-edge science, to then feed it into the model to basically work out whether the treatment that we're giving is working or not. And if it isn't working, then hopefully we will be able to either intensify or maybe even de-intensify treatment if the treatment looks as if it's working spectacularly well, so that we can really tailor a treatment solution that's bespoke for the patient in front of us.
It really is an exciting field at the moment, and I just want to say thank you for sharing your insights with us over the last couple of days. I look forward to inviting you back to ANZUP for you to share some of the results of the trials that you're running, and thank you very much for chatting with me.
Thank you so much, Lewis. It's been an absolute pleasure, and I've had a fantastic time at ANZUP.
Great, thank you so much.